Welcome to this presentation of DBS for Parkinson's disease. My name is Patrick Blomstedt and I am Professor in Stereotactic Functional Neurosurgery at the University Hospital of Northern Sweden at the Unit for Deep Brain Stimulation. I and my colleague, Professor Marwan Haris, have over the last 25 years performed about 800 DBS procedures for Parkinson's disease, and we have published our experience in a large number of scientific papers. My intention is to here provide a brief overview for patients suffering from Parkinson's disease and who are interested in learning more about this therapy. You will here get the same information as at a consultation at our unit, but in a more detailed and pedagogic manner. I believe that by having a good understanding of your disease and about the therapy you are receiving, you will be in more control of your life and that this will have beneficial effects both for your physical and mental well-being. However, I can of course here only provide you with general information without consideration to individual factors, and my opinions are based on our own experience and might not be shared by everyone. Before continuing, please have a look at the previous video, What is Deep Brain Stimulation?, in order to be able to fully appreciate the details in the current presentation. Parkinson's disease is a chronic degenerative disorder affecting the neuronal cells in the brain and changing their function. And since the neurons in the brain are connected in networks, a change in one area of the brain might affect the activity in other parts of the brain and give rise to a wide variety of symptoms. The most well-known symptoms are of course the motoric symptoms such as tremor in the hands, stiffness and slow movements, as well as affection of gait, balance and posture. But other symptoms might include anxiety and depression, cognitive decline and dementia, sleep disorders, speech problems, problems with swallowing, sweating, and constipation, etc., etc. These symptoms will vary between different patients and will also change over time in the individual patient as the disease progresses, and the rate of this progression will further vary considerably between patients. Hence, even though Parkinson's disease is a well-defined entity, there will be significant differences in how it affects different patients. Parkinson's disease is initially and most often treated with various medications, most importantly L-DOPA. As long as these provide a good effect, other treatments should not be considered. Usually, pharmacological treatments will be sufficient at least for several years during the so-called honeymoon period, before more advanced therapies will have to be considered in some patients. When a recently affected patient takes the L-DOPA medication, this will be transported to a storage in the brain and released gradually in a sufficient amount to the neurons to ensure a good symptom reduction, and the patient is then in the so-called on-medication state. Unfortunately, over time, as the disease progresses, the brain's ability to store L-DOPA becomes gradually more and more reduced, and the store will last for a shorter and shorter length of time after the patient has taken the medication. And when the store is depleted, the Parkinsonian symptoms will of course return. The patient is then in the so-called off-medication state. Another problem with the reduced storage capacity is that when the patient takes the medication, there is not enough room to store this, but instead an excess of L-DOPA will be released directly to the neurons and overflow these with too much L-DOPA, which might cause involuntary movements, so-called dyskinesia. Hence, the total time the patient has an optimal level of L-DOPA in the brain and is relatively free of symptoms will be more and more reduced as the disease progresses. Instead, the patient will spend more and more of the day with a too to low level of L-DOPA in the brain and with more symptoms, that is, in the off state. Further, when the patient takes the L-DOPA medication, this cannot be stored properly, which can result in involuntary movements. It is important to understand this cycle, so let me repeat this again. The patient will take the medication when entering the off state and will, after a short time, reach a good symptom control. But as more and more of the medication enters the brain, the patient will reach a too high level of L-DOPA, which might cause dyskinesia, before the level starts to sink and the patient enters a good level and good symptom control again for a while, before the L-DOPA level is further reduced and the patient enters the off state again. So over time, the effect of the medication will show faster and faster oscillations between too little and too much, with less and less time spent at an optimal level with good symptom reduction. And in order to reduce these oscillations, the patient will start to take smaller doses more and more often, and sometimes as often as every second hour. There are two types of advanced treatments for Parkinson's disease, pumps and surgery. When fluctuations in the level of L-DOPA is the major problem, then pump treatments with duodopa or apomorphine can be considered. However, these systems are somewhat cumbersome and need constant attention. Further, the effect of DBS is better, at least concerning tremor, why, according to the Swedish guidelines, DBS should be excluded as an option before considering pump treatment. So, we then arrive at the surgical treatment of Parkinson's disease, which today is more or less synonymous with deep brain stimulation. We looked in detail at how DBS works in the previous video, but basically, in Parkinson's disease, pathological neural impulses are propagated through nerve bundles through the whole brain and out to the peripheral nerves and muscles, where they will cause tremor in the hands and other symptoms. By implanting electrodes into the brain, we can introduce new impulses that will block the pathological signals and hence the symptoms. When a patient is referred to us for consideration of DBS, he or she will be evaluated by myself, our neurologist, DBS nurse, and neuropsychologist. DBS for Parkinson's disease is a complex therapy, and it's not possible for me to go into all details, mainly since different patients have different symptoms, since DBS has varying effects on different symptoms, and since there are 3 different structures or targets in the brain used for DBS, all with different effects on the various symptoms. I will, however, try to give an overview of this treatment, and in general, DBS is not better than pharmacological treatments, but it will have a better effect on some symptoms, why a combination of DBS and medication will be the best option in some patients. But DBS is for most patients with Parkinson's disease not the best treatment. DBS is not helpful for many symptoms such as cognitive decline, psychiatric symptoms, impaired balance, frequent falls, etc., etc. We will consider DBS if the medication is not providing sufficient relief regarding symptoms such as tremor, or is causing side effects such as on-off phenomenon and dyskinesias. The first thing we look at is the age of the patient. The brain is becoming more sensitive with age, and at some point the risk with surgery will be larger than the potential benefits. Opinions on how old is too old differs. We will not accept patients older than 80 years, but others are happy to perform DBS in older patients, and I don't know who is right. The DBS nurse will evaluate the patient according to various scales, both with and without L-DOPA medication. These evaluations are documented on video, so we can always go back after surgery to see what we have achieved with DBS. Importantly, the DBS nurse will also in detail discuss the aims of the operation with the patient, and the patient will write these down. If you are considering to undergo DBS, then it is important that you define for yourself what you want to achieve and what degree of improvement that would make you satisfied, and what impact you would expect this to have on your life in general. It is important that your expectations are reasonable, and if I believe that we cannot meet the patient's expectations, then I will advise them not to have DBS. The neurologist will examine the patient to confirm the diagnosis of Parkinson's disease, that the medical treatment has not been satisfying, and decide if further pharmacological treatments might be tested before DBS. The neuropsychologist will then evaluate the cognitive faculties. And finally, the neurosurgeon will make sure that there are no surgical contraindications, that the general health condition is acceptable, and that the patient has a reasonably healthy brain, as seen on MRI. Further, we will discuss the details of the procedure and make sure that the patient has reasonable expectations. Basically, we will accept all patients who have symptoms likely to respond to DBS to such an extent that it will have a significant impact on their quality of life, that have reasonable expectations and no contraindications. In most patients who are deemed not suitable for DBS, this is not based on one single contraindication. The typical patient who I do not suggest DBS has some cognitive decline, an MRI demonstrating atrophy or vascular lesions, is close to the age limit for DBS, and often has some other issues regarding his or her general health condition. When we have decided on surgery, we need to decide if we should perform a unilateral or bilateral procedure, that is, to treat only one or both sides of the body. Most patients will receive 2 electrodes, and unilateral surgery is only done in some patients with tremor-dominant symptoms who are deemed too old for a bilateral procedure, or where only one side of the body is really affected. We further need to decide in which brain structure to place the electrode, and this is done based on the patient's symptoms and other factors such as age. The subthalamic nucleus, or STN, is the target of choice in Parkinson's disease and has unquestionably the best effect, with a good reduction on tremor, an improvement on bradykinesia, rigidity, dyskinesia and on-off phenomenon, and the L-DOPA dose can be reduced. I expect a symptom reduction of around 50%, and this is in accordance with most reports in the literature. The VIM in the thalamus will have a good effect on tremor, but only on tremor. The VIM is mainly used in some elderly patients with tremor-dominant disease suitable for unilateral surgery. In general, I expect a tremor reduction from stimulation in this area of around 90%. Finally, the pallidum, or GPI, is another option. It is perceived as harboring fewer risks than the STN in some elderly patients and is sometimes chosen due to relative contraindications, especially of a cognitive nature. The overall symptom reduction is lower than what can be expected from STN DBS, but the effect profile might make it a better choice in individual patients. It will have an excellent effect on dystonic symptoms and dyskinesia, a moderate effect on bradykinesia and rigidity, a more modest effect on tremor, and there will be no L-DOPA reduction. We will further discuss with the patient and decide on whether to use a rechargeable or non-rechargeable neuropacemaker. These have different advantages and disadvantages, and we will try to find what is most suited for the individual patient. I have discussed the procedure in detail in the previous presentation. We perform the implantation with the patient asleep based on the identification of the target structure in the brain on MRI, and the location of the electrode is verified with an intraoperative X-ray investigation. But there are many variations in how the procedure is done around the world. Concerning complications, Stimulation-induced side effects, infections, hemorrhages, and hardware-related complications were also discussed in the previous presentation. In some patients, we see a postoperative edema. Immediately after surgery, an edema is formed around the electrode. Some patients will notice this as an improvement, especially if they have tremor, but a few patients might notice some unwanted side effects, often in the form of slow or slurred speech. These symptoms will disappear within a few days or weeks when the edema resolves. A few of our elderly patients have noticed a slight deterioration of the balance after surgery. This is not so pronounced that we have been able to verify this with our tests. In general, DBS is a safe procedure with few complications or side effects of a serious nature, and well tolerated also by older and more frail patients. However, the risk for other side effects will vary with individual factors, where the electrode is placed, and if one or two electrodes are implanted, and we will discuss this in detail with the individual patient before surgery. As I mentioned in the last lecture, the patient will stay a few days after surgery and return after 4 weeks to start the stimulation. In patients with unilateral DBS for tremor, the programming of the stimulation parameters is usually straightforward, and most patients will not need to come back for any adjustments during the first year. However, in patients with bilateral STN DBS, the situation is more complex, and the patient will return after 3, 6, and 12 months for adjustments. In these patients, it is necessary to gradually increase the stimulation strength while at the same time balancing the medication in order to get an optimal effect. We will evaluate the patient after 1 year and then every second year, or when needed. The patient is further equipped with a remote control. This is sometimes used for making minor changes in the stimulation. A rechargeable battery will last for up to 25 years and a non-rechargeable for about 5 years, and to change the battery is a minor procedure which is done in about 20 minutes with the patient awake or asleep. DBS is done in order to improve the quality of life of the patient, and after surgery the idea is that you should be able to forget that you have undergone this procedure. The implants will not break or change position if you fall or suffer a minor trauma, and you can virtually do whatever you want without taking the DBS into consideration. We are making our patients better with DBS, but to some extent this is a potential improvement that needs to be realized. Many patients with Parkinson's disease need to learn again how to use their body in a more normal manner. Therefore, we will send these patients for 3 weeks of rehabilitation. This is done 6 months after the procedure, when we expect to have a good effect from the DBS. Regarding the outcome, I consider that we have a good outcome in about 90% of the patients. But it is important to remember that DBS does not cure. It is only hiding some of the symptoms. Typically, with bilateral STN DBS, we will reduce the patient's symptoms with about 50%. I believe that about 90% of our patients are satisfied with the procedure. Some of them are very happy, while others are satisfied even if they had hoped for a better effect. The effect is rather stable over time. This means that if the patient had a good effect on tremor from the beginning, then this effect is likely to be retained over time. However, over time, the disease will progress and new symptoms might appear for which DBS is not effective, such as cognitive decline, psychiatric symptoms, impaired balance, frequent falls, affection of speech, etc. Thus, even if DBS retain its effect over time on some symptoms, there will often be a reduced benefit over time, since the problems of the patients are changing. And, unfortunately, in about 10% of the patients, we will not achieve a satisfying result, even from the beginning. I would also like to mention the risk of success. Some patients have a truly excellent effect of DBS. And for some patients having Parkinson's disease, this has become part of their identity and how others see them. And a sudden improvement might make it necessary for the patient to redefine who he or she really is, and the relation to family, friends, and the rest of society might change with new demands and expectations. And this can sometimes be a difficult process. So let us end this overview by looking at two cases before and after DBS. Here we see an example of a bilaterally implanted patient with tremor dominant disease. And we see that virtually all tremor is gone after surgery. And here we have another example where we see also the effect on slow movements. And also here we can see a considerable effect of DBS. And with that, I end this presentation, and I hope that you have found the information to be of some value. Thank you for your attention.